First of all, I just wanted to do a survey, and Allison is going to have you put whether you're an occupational, physical, speech, language pathologist, or a mental health professional. This includes behaviorists, psychologists, social workers. You just click it on so we can see. If you don't fall into any of those categories, like physical, let's see, who don't we have? Principles, you would hit other and then hit submit so we can do a quick live survey of who's here.
All right, so it looks like 90% of our audience is OT or OTA. We have 5% of our audience is PTs or PTAs, 2% SLP or SLPAs, and 3% saying other.
So there are two basic ways of intervening, and we're going to jump right in. Using sensory and interoception, we're going to either coach our clients, our students, say to use soap that disintegrates rather than water. If water really upsets them, or they really dislike it, or they get really hyper during water. So it's the kind of thing where you ask open-ended questions and use those to lead the parent and the student to the answers to their questions. You can specifically guide them if you need to, but you're trying to kind of help them see the answer if you can. And that's proven to be effective. The other one that I use in schools is sensory-based interventions, which I'll be talking about. These are individualized sensory strategies or adaptive equipment specifically designed to improve either their sensory modulation, which is whether you're hyper or under responsive, and their sensory discrimination, which is their body awareness and ability to integrate all the senses. Sensory modulation is the most important for behavior, but sensory discrimination, especially body awareness, is very important too. On the highest level, if they have body awareness, sensory discrimination would be if you wrote hat on a whiteboard, you've got the stink of the marker, you've got the to write hat, you have the visual of hat, and you have the kinesthetic sense of how it feels to form an H, an A, and a T. You can do it with your eyes closed. You've got to integrate all those together in order to be organized and feel confident as a student. So those are the two ways that we're going to talk about intervening. There's a third way called air sensory integration, which is what they do in clinics where the child leads the treatment. I don't do that in schools. It's good to sometimes have a kid who has the money go to a clinic, particularly if they're leaving a psychiatric hospital or have just had an acute episode. Usually the therapist meets with them for around an hour for, say, 8 sessions before their insurance runs out. And I found it's very helpful because the child's getting really good attention. It's been shown in research to help them with goal attainment, and it gives the parent an hour break. And then at the end of the session, you tell the parent what to work on as homework from your session. So it can really make the difference after kids have an acute episode, but I'm going to just talk about the two that I use in schools, which is the coaching and the sensory-based intervention. Now, just look at the blue. This is what we talked about last time, sensory modulation disorders. Being sensory sensitive is the one that is most associated with behavior problems and mental health problems. And as you can see under there, gravitational insecurity, being afraid you're going to fall, not having cruddy balance, but being scared of falling, and touch defensiveness are two subcategories of sensory sensitive. Basically, if you have any of the sensory modulation disorders, any of the sensory discrimination disorders, which I'm going to talk about next, and the third one, which we're not going to discuss today, but we can in the future, praxis and dynamic balance problems. Any one of those or all three of those, you've got a sensory integration or sensory processing problem. So if you have low registration, you've got a sensory processing problem under the subcategory of sensory modulation. You may have both sensory modulation and sensory discrimination disorders. So if your child does, you're going to first address what we talked about last time, which is sensory modulation, getting them in a calm alert state. And then you'll move on in your session to sensory discrimination, the orange stuff. If you look at the orange stuff, you've got the three that are our main areas of traditional sensory integration right in the middle. Vestibular, which is your movement sense, proprioception, which is deep pressure, and tactile, touch. And those three go together and are a foundation of sensory integration. But we also consider taste, gustatory, smell, olfactory, visual, and auditory. And those can be powerful, particularly if kids are not responding well to learning. You can then use smells or visual supports or auditory supports to help them to get it all together. And what I'm going to also mention tonight is interoception, which Winnie Dunn puts under sensory discrimination. And I'll talk about more tonight how this new thing, this interoception sense, which is proven now, relates to sensory integration, sensory processing in general, and how you're going to use it in your treatment. Just to review what we did at the last year's seminar, some kids are hypo-responsive. They don't respond to input that the rest of the class would. Some are sensory sensitive, hyper-responsive. They respond to things that other people wouldn't. And the reason is that their nervous system is different. So they're responding to noises like the radiator that the rest of the kids could tune out. And they also, it's been proven recently, have poorer ability to get used to stuff, habituation. So if a siren went by outside your house, you'd all freak out. But in 5 minutes, those of you with typical sensory processing would be back with us. Those of you who are sensory sensitive would still be upset 10 minutes later and distracted by the sound of the siren that happened 10 minutes ago. They're the people who don't like to wear watches or rings or neckties because they feel it all the time. And they're the kids who, once they become dysregulated, they're gone. So you have to keep them from getting so hyper responsive that they can't habituate anymore and they dysregulate completely. The thing that is hard for us to explain, but very important for us to explain to parents and children, are many children have both hypo and hyper responsiveness. I do too. I took the adult sensory profile and I come out hypo-responsive and hyper-responsive for my age, where only 2 out of 100 adults are that much. So people will ask, well, what does that mean? It means that sometimes when people give me directions, I don't pay attention to them. I forget or I don't tune in. Men get accused of this a lot by women. I tell him, but it just doesn't register. Well, that's actually true. But then, because I'm also hyper responsive, and many people are having a small calm alert state, I will overreact once I do register input and sometimes get overwhelmed. Like when I used to bring my son to Chuck E. Cheese's, I felt like I was going to vomit. People were smacking into me. There were strobe lights, noise everywhere, and it was just too much. So what the teachers will ask us is, what do I do? If a kid is hyper off the wall and causing problems, or, and we see this a lot in children who have abuse and neglect histories, under responsive and not learning, and we don't know which it is. I mean, what can we do with this child who has severe problems? And what I found is a most helpful rule of thumb to give to teachers is simply lower the stimulation. Either put noise canceling headphones on them like jackhammer guys or people who shoot guns use to stop the loud sound, or lower the room volume, put thicker walls, lower the lighting, decrease all the stimulation. If the kid becomes calm alert, you're good. If he's still hyper or under aroused, then take that state of decreased stimulation and, in a graded way, bit by bit, increase it in a socially acceptable way until the child becomes calm alert. I always think about it in scuba diving. If you scuba dive and you go down too fast, you get a splitting headache. So you've got to come back up and go down more slowly so that you get an equilibrium. And that's what we're trying to do with these children in our classrooms. And then we want the students to learn to do it themselves, to realize whether they're under or over responsive for what they need to do functionally and regulate themselves. I've literally seen people with sensory integration problems who are in prisons and people with equally severe sensory integration problems who are doctors and lawyers, happily married. The difference is the people who are successful feel they need to accommodate to the world, and people who are in jail feel the world needs to accommodate to them. So even early on, if they're not completely getting it, we want to begin to stress to our students that it's their job, not an easy job, but it's their job to learn to be a calm, alert state so that they don't hit anybody. And we're going to help them. And we know that it's hard, but it's their job. So that's the whole sensory modulation area. Can everybody see me okay?
You're
I'm
looking good,
going to
John. Yeah.
show you the first one to calm kids, and it's one they do themselves. It's called self-squeezing. And I would like everybody to try this with me, so I invite you to do that. Crisscross your arms and press diagonally down. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Pick a shoulder and either massage that shoulder or press down on that shoulder, whichever gives you an awareness of your shoulder better and more comfortably. Then go to your upper arm your lower arm, your hand, your thumb, pointing finger, middle finger, ring finger, and little finger, the side of your hand, the lower arm, upper arm, and shoulder. Now, if you really want to dig into this, you can close your eyes. If you're having more trouble, you can keep them open. Put your hand on your other shoulder and squeeze that shoulder or press that shoulder. Moving down, press or squeeze your upper arm. Press or squeeze your lower arm. Press or squeeze your hand. And then circle around with your fingers, your thumb, pointing finger, middle finger, ring finger, and little finger. Your hand, lower arm, upper arm, and shoulder. Now put your hands in your lap, close your eyes or look down, and notice the changes in your body. Notice your breathing, and notice your thoughts. The next one I use both as a classroom movement break and show teachers for a movement break is more around sensory discrimination, which is giving them a body awareness. This is also an interoceptive technique. I'm going to be talking to you about interoception awareness. The body scan is an interoception technique. Now I'll explain more about that in a moment. Close your eyes and imagine that a golden butterfly has landed on your head, emitting white light. White light comes down from this butterfly and it relaxes and energizes the top of your head all the way down, flowing white light to your neck and your face. So your head and your face and your neck have been bathed in white light and they're energized but relaxed. Now the butterfly has flown onto your right shoulder. White light comes down into your shoulder blades, your upper arm, lower arm, and each finger. He flies onto your left shoulder. White light comes down into your shoulder blade, your upper arm, your lower arm, thumb, pointing finger, middle finger, ring finger, and little finger. The butterfly then takes his golden body and flies onto your right knee, and white light goes down your right calf, your ankle, big toe, second smallest toe, middle toe, second littlest toe, and littlest toe. He flies onto your left knee, and white light goes down into your left calf, your ankle, and all of your toes. And when I'm doing this, I talk about left and right if the kids are developmentally on second grade level or higher. If not, I just say do one side and the other side, one knee and the other knee. As you probably noticed, there are some kids who, because of sensory issues, get dysregulated maybe hit you or bite you. Then they're really, really sorry when they calm down. They'll probably do it again, but at that moment, they're really, really sorry. There are other kids who think about how they're going to get back at you for being so strict with them. And they think about and plan it and put a tack on your chair when you're not looking. It's a different kind of behavior problem. I found mindfulness is very effective for that type of behavior problem, that instrumental, as well as for the sensory flying off the handle quickly, if you catch it early enough. But my favorite for the ones with instrumental aggression is called kindness, or a meta meditation. I invite you again to close your eyes or look down and think of a person or a pet that you unconditionally love, absolutely adore, and visualize that person or animal. May they be happy. May they be healthy. May they be safe. May they be happy. May they be healthy. May they be safe. May they be happy. May they be healthy. May they be safe. Next, I want you to visualize an acquaintance, somebody that you've met, maybe someone who greeted you at a restaurant, or a new staff member who you saw today at work, but you don't really know them, a new custodian or a substitute teacher. You could visualize them, but you don't know them. They're kind of a stranger. Put their image in your head. May they be happy. May they be healthy. May they be safe. May they be happy. May they be healthy. May they be safe. May they be happy. May they be healthy. May they be safe. Now I want you to think of our group, all of us on this Zoom call together, who came out tonight to learn something together. And each one of us, may we be happy. May we be healthy. May we be safe. May we be at peace. May we be happy. May we be healthy. May we be safe. May we be at peace. May we be happy. May we be healthy. May we be safe. May we be at peace. Now I want you to think of yourself. May I be happy. May I be healthy. May I be safe. May I be at peace. May I be happy. May I be healthy. May I be safe. May I be at peace. May I be happy. May I be healthy. May I be safe. May I be at peace. May I be happy. May I be healthy. May I be safe. May I be at peace. Keep your eyes closed or your gaze down. Notice any changes in your body. Notice your breathing. And notice your thoughts. My favorite one is called hand breathing. And this is one I made up for kindergartners and preschoolers, but then have used in the older grades. Obviously, if a child is fisting, or if a child gets easily upset when they have to write, and they've been writing for 4 years, we have a concern. Their hands cramp, if they're just learning to write, they're in preschool or kindergarten, they have to write an hour because that's what our curriculum says. I expect that their hands are going to probably cramp up, and I'm going to teach the preschool or kindergarten teacher to do this. So what I do is if I have 3 kindergartners in a particular classroom, I schedule them on Wednesdays, 9 to 9:30, 9:30 to 10, and 10 to 10:30. Then, with parent permission, I spend 20 minutes individually with each of them. I spend 20 minutes with all 3 of them in a group. And then once I've taught them the different strategies, I go into the classroom and do it with the whole classroom. And these children are able to keep up because I've already been working on it for several months in individual and group. In addition, it's going to help the whole class, and it's going to give the child a lot of breaks during the day, which will help his behavior. Let's, what I say, open your hands and separate the fingers. When I say close your hands, I want you to make a fist and put the fist, instead of putting it in your palm, like this child, put it over your pointer and index finger. So when I say open your hands, you're going to extend and separate your fingers. When I say close your hands, you're going to make a fist with your thumb over your pointing and index fingers. Ready? Open your hands. Close your hands. Open your hands, close your hands. Open your hands, close your hands. Now, I want you to slowly open your hands as you breathe in, 2, 3, 4. Breathing out, close your hands with the thumb over the first 2 fingers. Open, 2, 3, 4. Close, 2, 3, 4. Open, close. Now I'm going to make it developmentally higher. Open, so that when you can't open anymore, you can't breathe in anymore. Close, so when you can't close anymore, can't fist no more, you breathe all the way out. Breathing in and breathing out. And I'm going to make it even harder developmentally. Breathe in, so when you can't breathe in anymore, your hands are open. And at a slower rate, breathe out. So when you can't breathe out anymore, your hands are fisted. Breathing in, breathing out slower. Put your hands in your lap. Notice the changes in your body. Notice your breathing and notice your thoughts. I'm not going to go over all of these, but I think of mindfulness as a sensory modulation activity where I'm calming children and I'm decreasing their arousal level so that they don't get so hyper that they're going to become aggressive. Slow breathing activities reduce anxiety, depression, and trauma symptoms in children and adults, including adults with psychosis, which is a very serious mental illness where they hear things that no one else hears, post-traumatic stress disorder, depression, anxiety, OCD. Mindfulness training significantly decreases bullying behavior in schools by children who are bullying. Feel Your Feet, which is another one I'm going to teach you, was developed by a behaviorist, and it's been used to help typical middle school and high school children who are going to be expelled for violence. It also helped adults with Prader-Willi syndrome, a genetic problem where Thorazine was not able to help them. Sensory coping strategies that improve anxiety and depression work through neurotransmitters in our nerves that are our chemical signals. And the effects can include mindfulness, deep breathing, sensory strategies, massage, and exercise. So exercise, massage, sensory strategies, deep breathing, and mindfulness, yoga, I consider those all sensory modulation strategies that can be used specifically depending on what ones your students best respond to and enjoy doing. I'm going to feel your feet for you. So close your eyes or look down. Pick a foot. Think of your toes and feel that big fat toe. Next to the fat toe is the second toe. I want you to feel the fat toe and the second toe. See if you can feel your socks. Or if you don't have socks on, your actual shoes or sneakers. Try to add in your middle. So you got the fat one, the middle one, and the second smallest one. You've got three. You can bend them if you can't feel them. Now the second smallest, add that in. So you got the fat, second, third, second smallest. You can bend them or feel them and add in the little toe. All 5 toes, put all your attention on them. Move back and you got this ball of your foot. So you've got the toes and you're feeling the ball. Toes, ball. Go back further and you've got an arch. So you've got toes, ball, arch, toes, ball, arch. Now in the back, add the heel. Toes, ball, arch, heel. Toes, ball, arch, heel. Put all your attention on your feet and you can open your eyes. So those are all coping strategies. They also decrease arousal level. They're those sensory modulation that we talked about in the previous seminar, and they're your most related, especially the hypersensitivity, to misbehavior and mental illness, as well as autism and other developmental problems. And when I say related, they're not the same. About 80% of children with autism spectrum disorder also have sensory processing problems, primarily hypersensitivity along with others. 20% don't. So they're different problems, but they happen a lot together. With depression, anxiety, OCD, it's around a third of the people. With OCD, depression, anxiety, about a third of them also have a sensory processing problem. PTSD, around a third of them. Post-traumatic stress disorder. So the reason that I'm teaching you these are a lot of the children who have behavior and learning problems because of developmental or behavioral mental health problems are more likely to have sensory problems. If they don't, we're not going to treat sensory problems because some of them don't. But if they do, we're going to treat both. So I reviewed the sensory modulation and I got a little bit into sensory discrimination. And the 3 we're going to talk about when we talk about sensory integration in general, or sensory processing. Sensory integration, sensory processing have 3 pieces. If you have any of these pieces, or all these pieces, you got it. Sensory modulation, sensory discrimination. So the 3 things we think about are touch, movement, which we call vestibular, and proprioception. And proprioception is the one that I've had the most confusion. So I spent hours researching it. There's two types of proprioception. There's the proprioception that neurologists talk about, and there's the proprioception in sensory processing. First of all, the one that is talked about in neurology as well as sensory integration are the muscle spindle fibers and Golgi tendon organs that hang out around joints and work with the movement system. And they're what enable us to be coordinated in our movements. You've probably seen a lot of kids who simply have sensory processing problems, but look real clumsy. They don't necessarily need physical therapy, but they walk into desks even though they see all right. They trip a lot. They walk into desks. And this is primarily because of this proprioception. The way to explain it to parents is this is my elbow and my eyes are closed. How did I know it was my elbow? Because I can feel it. I've made a letter D. You may have seen it as a B, but I made it with my eyes closed. How did I know? Because I have a kinesthetic sense in my muscles and skin that tells me what it's like to form a ladder. The reason us OTs get all bent out of shape about feeling your hand is if you can't feel your hand, you're going to have trouble using it. You're going to have to compensate with vision. And if your vision's off too, you're going to have some serious problems. In sensory integration, we also talk about tactile and proprioception together as both deep pressure, the proprioceptive part, and moderate or even what I'm going to talk about today, light touch. Light touch not talked about, but can be powerful, and I'm going to tell you how I use it. But giving deep pressure or moderate touch, either through pressing or to get other people to do it, like psychologists, nurses, psychiatrists, teachers. I use a vibrating bath brush that I get from CVS, and I just will. Most kids have gone to the eye doctor, so I'll rub it on their back. I'll just do one side of the spinal column so they don't cross midline and they don't have to deal with crossing the corpus callosum of the brain. I'll just do one side and I'll say, what's better, this way? And I'll leave it on vibrating, and then I'll vibrate it, it turns green, and I'll say, or number two. If they say number two, I'll do it vibrating. If they say number one, I'll just press. And what's good about this is I'm not touching the child. I'm touching the brush. The brush is touching the child. So a lot of people will do this who are non-OTs, or even OTs who are uncomfortable can do this because you're not actually touching the child. And I have a place on my Fab Strategies form where the parent can give us permission to do touch or to do a vibrating bath brush touch. Proprioception in sensory processing helps with both body position, that sensory sensitivity, and alerting, the sensory modulation for attention and learning. So sensory modulation piece would be that calm alert state, and the body position state would be knowing where your hand is, knowing where your elbow is. You can also play with the parts that you want them to learn. Tell them to close their eyes or even leave them open. Where's Mr. Jiggle? He's on my hand. He's on my elbow. He's on my cheek, my upper lip. So you can use it in that way, or you can use it without the vibration in that way. And again, your hand's not actually touching the child. So it's more comfortable for like teachers and stuff. Assess specifically whether proprioception and tactile, and especially proprioception, can backfire. Makes the kid more functional or less functional. So if you're going to have a kid do proprioception by jumping on a mini trampoline, have him do it and see afterwards, does he do better in school or does he trash the room? If he trashes the room, you don't want to do it, or you need to modulate it. Most kids are short, so I'll put my hands on their shoulders, and as they jump, I'll be giving them deep pressure, or I'll slow them down, and they can only jump when I clap. If that doesn't work to make them more functional through the deep pressure, I wouldn't use the mini trampoline. And that's why a lot of people ask me, there are psychologists who do somatic psychology. Usually it's like a 2-week course. They have some good ideas, but they're not going to have the expertise of OTs because we do it all day long. So it'd be better if they teamed with us, and then we could really make sure to put a bunch of junk in a room, a bunch of equipment, is not using sensory processing. It's putting a bunch of junk in a room. A sensory coping room has specific stuff that's going to make that child more functional. It's going to address his sensory modulation and or his sensory sensitivity so that he is more functional. It's very specific. To just let them randomly get more and more hyper is not sensory processing. So I don't mind other professions using it so long as they use it with an OT or they've had enough training that they're using it correctly. One thing I do is press on a child's shoulder or have them press on their own the way I showed you, where you're going diagonally toward midline. And the shoulder squeeze along with deep pressure, either pressing on the skin or brushing on the skin, has been found to help children to become more calm and in a better mood when they have autism and intellectual disabilities. And I call this sensory-based intervention. We use a sensory assessment like the sensory profile. We figure out what the kid needs through clinical, and we figure out how to integrate it into the classroom routine so the kid learns better. They take pieces of sensory-based interventions and they use them in PBIS and somatic psychotherapy, but they don't necessarily use them optimally. And also in the Smart Art program, they use sensory rooms, but the OT who they had helping them is no longer with them, and so I worry about it. That's just my opinion on that. This was something that happened a week and a half ago, and I was just so touched. A child who never speaks, the boy on the bottom there, the teacher decided to have a playground time, and I went out with the class. They're integrated into a regular playground, but our kids kind of stuck together. And this little boy never talked, but he said to the big boy, "Joey, I need you," because he couldn't turn this spinning thing by himself. And so the kid didn't come, so he called him again, and he came, and another kid joined them, and together the three of them did spinning, which is in your inner ear, you have that movement system, and there are unique receptors in the inner ear, vestibular receptors, that are only facilitated by spinning, either on a playground equipment like this or on a suspended swing that spins. And he wanted that input, and it got him talking, it got them working together. And you can see that they're also getting a lot of proprioception. Proprioception and movement often go together with language, and it's a really great way to facilitate it. And it's going to be better if you can do it in a natural environment, like on a playground or by having classroom pets. The other thing that, I really think is important now in the schools more than ever is working with the children with post-traumatic stress disorder. The ARC program had a consultant for us for a whole year, and I was talking about how the young ladies who had been traumatized were misbehaving in class and hitting the teachers. And the expert, her name's Christine Kennyberg or something. I call her Kenny Buggingport, but it's not. It's like Christine Kennyberger. She was our consultant, and she was like, John, have them ask for a break. And if they want a break, give them a break. So that became our rule. But the teachers started getting mad at me, and they're like, they're milking it. They don't really need a break. They just want to get out of class. So it's like, Christine, what do I do? She goes, well, that's not true. But tell the teacher it's up to them. So I did, and the teacher got really badly punched. So then they all started saying, yes, you can go with John if you ask politely before you're aggressive. So this one girl asked, and I put her in a cuddle swing. So you're getting a lot of proprioception from the swing itself. And then I'm giving very hard pushes, and I'm just going linear. You don't want to do too much spinning, because spinning can get the hyper piece too off. So you've got to be very careful. So when a child's dysregulated, I just do forward and back with really hard pushes, and this is containing them. And this is a good example. Watertown, it's a sensory integration place in Massachusetts, where Jane Kumar worked, one of the beginners of sensory integration. And she said to use womb space. So I bought this cuddle swing. And for this particular girl, it worked like a dream. She said, I need to come to you. She's swearing about the teacher. I don't say a word. I put her in this and I push her, and she finally calms. I don't talk to kids when they're out of control. You're seeing kids who, when they're gone, they're gone. You need to bring them back to calm alert before you can talk to them. So when I finally got her back to calm alert, she said, I have to visit my mother today right after school. And my mother burned down the house, killing my father and my brother. And now I have to see her in prison, and I'm really upset. And I just don't know what I'm gonna do. So she really needed a break. This helped her, and then I sent her back to class, and she was able to calm. What Christine said is they don't want to hang with an old guy when they can control themselves. And sure enough, once the kids learned how to calm themselves, they didn't come to me anymore. But I also show this because this can backfire. One time I put a child in one of these, and the child's eyes widened, which is a sign of hyperarousal. So I immediately used the back of it and threw her out. And then I said, what's the matter? And she said, like with no affect, well, I think I'm upset with your swing because one time my dad put me in a car and forgot me, and the water sweated out of me, and I got really sick, and a policeman had to break the window to get me out. "What's wrong, John?" And I have a very expressive face. I said, "It makes me very sad to hear that happened to you." So that's why I say it needs an OT or a very experienced clinician, because a cuddle swing does work. The idea is womb space and it's around you, some great probe, but it's not going to work for everybody. If you had a bad trauma experience with being enclosed, we need to be able to see that and respond. In the program that I use with all the therapists, we use environmental adaptations, sensory modulation, positive behavioral support, and physical self-regulation. I think it's important that we know the research, but we might use stuff like a vibrating bath brush that doesn't have tons of research. It's only got a little, because I often will use brushing instead of before the physician uses Thorazine. And my feeling is it's an individualized intervention. It has some research evidence, a tiny bit, but it meets with the client and family's values. It's in the environmental context that makes sense. And the benefits highly outweigh the risks when you compare it to Thorazine or even Valium. My environmental adaptations would be to prepare and limit transitions. Sensory modulation would be things like hand breathing, whether it's open your hands, close your hands as a distraction, or breathing in, breathing out. And this is called a mudra, a handhold to decrease rage, which is also a calming and spiritual position that supposedly infants are in utero. It's called Mushti Mudra. So I have them stretch out their hands so they don't cramp when they're writing, and then I have them do Mushti Mudra. And the out breath longer than the in breath, and the breath slower, which has been shown to calm the nervous system. An idea of positive behavior support. Some kids will slap me and then say, "I was only kidding." And I'd say, "You don't always kid well, so you need my permission." "John, can I kid with you?" "No, I'm not in the mood." "John, can I kid with you?" "Yes." And I do the same. The same with touch. I make them ask for touch. They can't just grab somebody and hug them. And I ask permission before I touch anybody. And if they say no, I don't touch them. Push-ups or wall push-ups are a physical self-regulation. And as I said, they can be as much as a breathing strategy or a net swing. I might use exercise as a calming, particularly if they have men teachers, because they think that I'm punishing the kid, but I'm really not. When a kid's getting hyper aroused, I show the teacher the signs, and then I say, "Let's do 5 push-ups," and both the teacher, me, and the kid does 5 push-ups. Now, I'm not punishing them like a Marine. What I'm really doing is deep proprioception through all the joints with linear movement, linear vestibular, which is calming. And if a kid is under responsive, it will also help him. So it's a safe one to use. But all these in yellow are proprioceptive, mindfulness, activities. So the majority of my activities, all those I highlighted, are all working in those areas. About 15 minutes after this seminar ends, I'll have this up on my website if you want more information. It's just got a couple of slides that I didn't send you because I wanted to make sure that you had this if you wanted to reread it. The final thing that I want to talk about is the one that confuses people the most, but I think that it's powerful and you can integrate it into your school therapy very easily. Interoceptive awareness is part of interoception. Interoceptive awareness is the ability to sense and represent your internal body states and functional skills. It's different than sensory integration. As I showed you, some people include it. But Winnie Dunn is making a occupational therapy assessment of interoception. And what she found in adults was that it moderately correlates or goes along with sensory processing. So it's different, it's distinct, it's not 100% the same, but there's some relatedness, some significant relatedness. And an idea of an OT interoceptive question is, I stay away from activities where I think I could get hurt. So if you're so sensitive to pain that you stay away from playgrounds or anywhere that you could possibly get hurt, then it's going to negatively influence your participation and your learning. So it's a functionally important thing. It's different than proprioception in that interoception is carried by different nervous system neurons. They're unmyelinated. They don't have fiber around the hose to make it go faster. They're unmyelinated. They're 1A fibers, and they're only on certain body surfaces. But this has become a fascinating area for us therapists in mental health, in massage, in occupational therapy. What runs on this interoceptive system is pain, itch, the need to go to the bathroom, feeling hot, and affective, interpersonal touch. They all run on this system. So we've begun to look at using light touch to give this interoceptive cuddling input. We've also worked on helping people to understand their internal body states, their interoceptive awareness, when they're hungry, when they're tired, when they need to use the bathroom or don't, because these are very important things that cause children to become dysregulated. And if we can begin to help them to understand them, then we can help to prevent problems. It's different than a push-up. Push-up is proprioceptive. A light touch, like a paintbrush on your arm, is an interoceptive touch, and it only is on certain body surfaces. You can't do interoception on the palm. Interoceptive and body awareness are also the foundation for our emotions and self-regulation. They're beginning to find in the research that we just feel something and then we say, oh, I think this is nervousness. What many children tell me is I feel wrong and then I punch. I feel bad and I punch. We want them to have more distinctions. I feel hungry and I need to get something to eat, as opposed to I feel wrong and I punch. Interoceptive awareness treatment enhances interoceptive awareness through the insula functioning. It's been found to be helpful in post-traumatic stress disorder, in autism treatment, in chronic pain, obviously, and even in anorexia, bulimia, and other eating disorders. So it's important, and I think we can easily begin to find ways to integrate it into our sensory integrative treatment or sensory processing treatment as a separate thing that's related but different from sensory processing. We originally had put it under the sensory discrimination part, but I think given the research that shows it's only moderately correlated, we have to think of it as something slightly different, where there are certain times when we will or won't use this light touch. I'm going to show you how I use it both with young kids and even with high school kids. They'll ask me, John, crack an egg on my head. I learned from a brain gym instructor how to use this, and then I modified it to add interoception. So what I want you to do is you make a fist. Pretend in front of your fist, where your screen is a child's back. So we're doing this on a child's back. We're going to start with an X. It's going to be very light, and it's going to be very slow, and it's providing interoceptive input. And I very slowly and lightly go across their whole back saying, X marks the spot. What you say is in bold. What you do is in italics. X marks the spot, and then the rest is hard proprioception with a dot, 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 and a line, 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 and a question mark. Then you put your hand on the kid's head, slap your hand, and let your little fingers go down the head. Crack an egg on her head, let the yolk run down. Crack an egg on her head, let the yolk run down. Creepy crawlies up your spine. You're putting your knuckles on the two sides of the spinal column, and then deep pressure down. Creepy crawlies down. It's going to be alerting, and it's also going to begin with some interoceptive input. And kids who are high school gangbangers ask me to do this. This becomes the cool thing to do. I don't let the high schoolers do it on each other, because when they do the egg, they hurt each other. So only teachers can do it. Do it one more time. X, light and slow. Marks the spot with a dot, 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 and a line, 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 and a question mark. Crack an egg on her head, let the yolk run down. Crack an egg on her head, let the yolk run down. Then up the spinal column, creepy crawlies up your spine, creepy crawlies down. Some of the ways, I'm going to end with this, and if you want to explore it more, Interoceptive Awareness School Curriculum, a lovely OT named Mailer. She teaches a curriculum for the school of gradually teaching, it's only for autism spectrum disorder, gradually teaching those children to be aware when they're hungry, when they need a break, what the signs are when there's butterflies in their stomach, all of these things. It's a curriculum, and she has 2 books out, and she has a couple of studies beginning to show that this is helpful in learning with children with autism. I think it's going to have implications for other children with interoceptive problems as well, but she's focusing now on autism. Mindfulness, I do breath, body, mind classes. If you email me, I put my email on the first page. I lead a class online from 5 to 5:45 every Sunday. So if you want to join my free online class, just email me. I'll send you the link. It's a husband and wife psychiatrist who came up with the slow, deep breathing. And in fact, they developed it because the husband gives advanced medication. And there's times when, like, a pediatrician's given a ton of medicine, then the family doctor, then a psychiatrist. Pretty soon, this kid is on so many medications that they don't know what's working, what's not working, if it's making it better or worse, and have to do what's called a med wash, take them off everything. And the kid's going to freak out. So by doing these breathing exercises, it helps reduce anxiety and aggression when kids are doing this med wash. And then he began to get grants to do it with all kinds of people in trauma. I did a group with him for psychologists who are working with the Ukrainian psychologists. They've done it with the young girls who were kidnapped and tortured in Africa. So they become a go-to group. And it's very simple, fun, musical, but any kind of mindfulness that someone will do is fine, or exercise. The body scan procedure increased interoceptive awareness. I showed you one I use for developmentally disabled children and young children, where the butterfly goes on their head, both shoulders, and both knees. If you go too long, it's going to be too difficult. You want it to be easy enough that they can do it, but hard enough that they can't think of nothing else. So that's your key when you're doing these exercises or mindfulness or anything. It's got to be fast enough that they can do it, the group or the kid, and it's got to be slow enough they can't think of nothing else. If you're listening to me, then you're mindful. If you're thinking about the TV show you're going to watch in a few minutes when I'm done, you're not mindful. And we go back and forth all the time. We want to teach kids to get mindful when they need to be mindful, like a hard subject. I gave you some interoceptive self-touch. So if we can't touch the kid, let's have the kid touch himself to gain body awareness. Mindful awareness in body-oriented therapy. I took this training. It's called MABT. It's similar to massage, but OTs can do it too. It's just very simple touch to give body awareness. And it's been proven to help adult women who were abused to not relapse in their substance abuse treatment. It's now being found helpful for opioid addictions. So it's a mindful kind of touch, and self-touch is part of it as a homework, in order to begin at the body for people who can't do mindfulness yet. It can lead to the ability to do mindfulness or meditation. And I think yoga is doing exactly the same thing. If you think of a downward dog, it's a push-up position. It's proprioception through all the joints. And then light touch, cuddling, slow, rhythmic touch on glabrous skin. The back is glabrous skin. So that's where I came up with the X marks the spot part in order to give that input. I've hit you with a lot of advanced things and concepts and stuff. So I'm going to turn it over to Allison to see if anybody has any questions, anything they want clarified, anything I didn't explain well, anything at all.
Perfect. So yeah, you guys can type those questions right in the questions box. And John, we've got a couple coming in now. The first one is, does the kindness exercise derive from the Ho'oponopono technique? I hope I'm saying that right.
I don't know, but it's called, because they wanted me to be nicer, the state paid for me to go to this place called Kripalu and the Omega Institute. They paid for a whole week of training. And I took all these advanced courses, even though I'm not a yoga therapist. I took yoga therapy, and I took advanced mindfulness. It's called meditation. And if you did it, it would be an hour, and you would get into like someone you hated, like your ex-wife. I don't take it that far with these children with aggression. I just have changed it so that it's someone you adore or an animal, because some of the kids couldn't think of a single person that they loved. You know, they had been abused and they really had no parent. You don't want to go, I can't think of nothing. So it could be a dog or a cat or a guinea pig or a mom or a dad or an uncle or a sister or a brother or a friend. Someone that you just love, love, love unconditionally. Then I go to a stranger, because I want them to get empathy, to know when they hit a staff member they don't know, maybe they know their face, but they don't know them, they're hitting another person, another human being like themselves. So a stranger, but someone they can recognize the face. Then our group, whoever our group is, like you as the OT and the kid, or the group of 5, or the whole classroom. And then themselves. Those are the only 4 I do. I couldn't do like people you don't like a little bit. I never got that far. But it's called the meta meditation, loving kindness.
Great. What do interception goals look like?
Interoception goals are OT goals, like that the child will tolerate 20 minutes of work without needing to go up and go use the bathroom, or without complaining of needing to go to the nurse. It's especially helpful for chronic pain. Those kids who have to go to the bathroom, it could be a component of that. There could be other reasons, but have to go to the bathroom every minute. So you could set, behaviorally, you could set a timer. They have to wait 5 minutes to go to the bathroom. But then I would also do interoception so that they get a sense of their body and can begin to feel. Also kids who are incontinent. So that type of thing, you can integrate it. If they like the X marks the spot, I did a lot of that with abused kids. People thought I was out of my mind, but I always say, can I touch you? And they say yes. And knock on wood, in 40 years of therapy, I've done this with Hasidic Jewish college students. I got the rabbi's permission because nobody's supposed to touch their husband. I've done this with girls who have been sexually abused, physically abused, emotionally abused, boys who have been physically abused, emotionally abused. If you bring the touch as a loving thing you would do to your child, and you have permission, it's usually safe. But again, read the body signs, just like we read, the eyes getting wider, the face turning red, the same way we would use autonomic signals when we were spinning a kid. We want to use it to look at their emotional state. Make sure they're okay with the touch.
All right. And can you review the mindful clock?
Yeah. Why don't you do it with me? Put your hands on your elbows. Oh, well, let's do the whole thing. So you have a zipper, but don't touch yourself. Ready, set, zip. Zip your lips. Sign language chair. And then you decide the self-touch. Hands on head, hands on nose, hands on ears, hands on lower lip, hands on upper lip, hands on nose, and hands on shoulders, hands on elbows. So as long as you end with hands on elbows, and if you just do head, shoulders, they'll ignore you and just do it. So mix it up what they're touching. Then your hands are on your elbows. Lean forward, lean back, lean forward, lean back, lean forward, lean back. Find your center, stable, steady place. And what you say is tick, and I'll put this on the slide too on my website, tock, like a clock, till we find our center. Tick, tock, like a clock till we find our stable center place. Then you're going to rock to the left. Tick, tock, like a clock till we find our center. You as the OT are going to go opposite to the kid. So you're really going to go to the right. But they're going left, 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 center, stable place. And what it is again, I would say to the kindergarten teacher, you know how I take your kid out of class because he falls out of the chair onto the floor? He has postural problems. So what I do is I put him on a therapy ball and I press in and down, body riding on the body, and I go, tick, and if you pushed me backward, I'd go forward so I don't fall over backward. If you push me forward, I'm going to extend so I don't fall on my face. So they're doing their balance, writing reaction forward and back. And then if you pushed me to the side, I'd flex my trunk and my head so I don't fall on the floor. And the same with the other way. So you're teaching writing reactions, and then once they're doing it in class all the time with their peers, you could put them on a therapy ball and they'll be more relaxed as you facilitate the writing reactions.
Okay, great. What is your go-to technique for an elementary student who is so hyperactive and has no safety awareness?
I would come up with 1 or 2 safety awareness goals. We as OTs are both blessed and cursed that we want to make everything better right away. And that's good, but you can't do it. So say, what is the most dangerous thing he's doing or disruptive right now? Say it's walking into desks. It's probably a visual and or proprioceptive problem. He doesn't know where his body is in space. Not like the Dalai Lama, like he can't feel his body. So you're gonna do some proprioception. You're gonna put stop signs on the other kids' desks. You're gonna put the kid next to him further apart than the other desks and give some things if he's walking into desks. So pick 1 or 2 that are your biggest safety concerns. Address them first, both through your adaptive equipment, optimally stable sitting, and also through rewarding him for doing a better job. So you're working both sensory and behavioral simultaneously. Because often now the Winnie Dunn's sensory profile 2 can distinguish behavior from sensory, and almost every kid I test 6 years old or older have both problems. They have significant behavior problems and significant sensory.
All right. Have you utilized these techniques virtually?
Yes, and the class they make you the husband and wife psychiatrist of Breath Body Mind got a huge grant during the pandemic to give us teachers free courses, and they were telling us the pandemic was going to only last 2 weeks. They said, Bull, the pandemic's going to be at least 2 or 3 years. It may be permanent. You all have to be able to teach online. So they specifically required that I be able to do all the mindfulness techniques online. And you can do, as I said, the crack the egg on the head, you can teach that online as well. You just
Great.
have to be very careful where you're standing. So like I enlisted my sister first, and she made sure that I was giving her enough time to process and that she could see me. She just said, I can't see you, John. So I would masking tape where I need to be so that she could see my different movements, because they're standing ones and that kind of thing. Then I would get a small group, like That's why I do my group every Sunday. It gives me a lot of online practice with leading mindfulness.
All right. Any suggestions for a preschool boy who constantly has his hands in his pants, seems to be motivated by combined self-stimulation, boredom, and anxiety?
A couple of things, and this is again where I think it's so important. If you don't have a behaviorist, you will have to use behavioral techniques, but they're not rocket surgery. Behavioral techniques, I'm sorry if I offend anybody, are basically dog training. Very simple. So if you don't have a behaviorist, you're going to have to do it. But if you do, I work with my behaviorist, and you want to do both. Like, for instance, behaviorally, you reinforce them, you get a baseline. That's very important. How often is his hands in his pants? Every 10 minutes? Write it down. It's not research, but write it down, because often when I'm coaching people, they're making improvement. They just don't know it because they didn't make a baseline like I did before we started. Then you can see if you're going the right direction. So you can make him go to the bathroom. Every time he puts his hands down his pants, he has to go to the restroom. That is one technique. If he enjoys playing with water in the restroom, you're going to have to come up with something else. But that's what I do. I make him go to the bathroom. If he's going to put his hands down his pants, that's the behavioral piece, and he gets sick of doing that. Sensory wise, I might do light touch on the head and different things like that. I would also have a reinforcement system where, as he goes longer periods without his hands down his pants, he earns something. And I would do that privately, not in front of anybody else, but he would know that he was getting rewarded. And again, depending on his developmental level, you could deal with that. So it's an okay thing to have your hands down your pants, but it's got to be in private. So often we found making the children go to the bathroom every time is helpful. Also, making sure they're busy. A lot of times with the older clients, they haven't had any functional activities for them. So again, if you go online, I have a list of my newest fab strategies, and I have some strategies in the sensory area. Like it's a merry-go-round thing. You hit a button and the merry-go-round goes around, and then two apps, Big Bang Patterns, they're iPad apps, Big Bang Patterns and Maestro. And you hit a touch switch or you hit the screen and music plays and stuff happens. So those are things I found successful for kids who had no activity they liked except eating. So that's why I came up with those, and I would try those if you don't have activities, because then you have no reinforcer and you have nothing for them to do, and you're going to see more inappropriate behavior and self-stimming.